Thank you. At the onset, let me thank the All India Ophthalmic Society Scientific Committee, Dr. Namrata Sharma, for giving us this opportunity to be in this wonderful conference and to conduct this instruction course. And I thank each one of the co-instructors for consenting to come here and give their deliberations on the subject. So we have an international faculty, Dr. Fosika Oreta from US. I'll be introducing her shortly. She will be delivering the keynote towards the end. She'll be talking about corneal complications of cataract surgery. We have Dr. Minu Mathan, who will be talking about IOL centration and the angles, angle kappa, angle theta, etc., in connection with the unhappiness of the patient. Dr. Matthew Kurian will be talking about dysphotopsias. Dr. Manusri will handle higher order aberrations and also residual cylinders. Dr. Sandhya will talk about the posterior capsular issues, and Dr. Akanksha will talk about the retinal causes of unhappiness. And we have Dr. Fosika Oreta. She is the Professor of Ophthalmic Education and Associate Professor of Ophthalmology and in charge of the residency program, Director at the Eye Trauma Center, Wilmer Eye Institute, Johns Hopkins University School of Medicine. A hearty welcome to you, ma'am. And I also welcome all the panelists. And I will start the session on the overview of the possible causes of unhappiness. See, we all know nowadays cataract surgery has become almost a refractive surgery, and the expectations of the patients and the promises of the ophthalmologists have become so high that any small error can cause a lot of unhappiness to the patient. So let us go through the few common complaints. One is the patient cannot see properly for far and near. Probably regarding the far, obviously, since we're talking about patients with 6/6N6, it may be a residual cylinder or a small residual sphere which can be corrected with glasses, but the patient, it may be a monofocal IOL, but the patient wouldn't have been explained properly that he may need glasses even for fine far vision. Near vision, again, if a patient is not been explained to properly about the need for reading glasses in a monofocal glasses or in a aspheric lens, which is not multifocal or EDOF, the patient may say, I was not told to this before, and it creates an unhappy patient. Dysphotopsias, yes, very important, especially in premium IOLs, especially the multifocals, trifocals, and EDOFs. You can have positive and negative dysphotopsias. Can't see in normal light. This can be a complaint when you are dealing with patients who are undergoing multifocals, trifocals, etc., because the light is being split for far, near, and intermediate. So the person in his younger days must have been reading in a dark corner of the room, and he may expect the same to happen. But then you may need to tell the patient that you need more light to read after the surgery. Night driving issues, definitely because of dysphotopsias and due to other reasons. Can't see very fine print. So this is expectation versus reality. And color perception problems, especially when you have a dense cataract. Initially, you may see the primary colors, the red and the blue, more vividly. That may be a disturbance for the problem. Most of this can be settled by a good counseling preoperatively. And the other complaints, obviously, it's not just about vision. The patient can have itching, watering, discharge, etc., especially since if they are not cleaning the lids properly, or they clean the lids initially and then stop it after a month or so, they develop blepharitis. Okay, eye pain, it could be due to a delayed post-op uveitis, or it may be just a neurological phenomenon. Photophobia, yes, definitely if the patient has got dry eye. Cat eyes, many times, especially in the spheric IOLs, not the aspheric ones, you can have this cat eye reflex when the patient moves around, and that can be disturbing to the patient. And sometimes they can say it's too bright or too dark. Too bright, especially when the patient has had a significant cataract with gross loss of contrast, and too dark, maybe in a subtle CME, etc. And so we need to deal with this by in these following headings, like the ocular surface disorders and the dry eye, which could be a very common cause of happiness. Higher order aberrations, Dr. Vanisri, I think she's on the way. She'll be dealing about the higher order aberrations. The IOL alignment, tilt, the angle alpha, angle kappa, all this will be dealt with Dr. Minu Mathan. Dysphotopsias, Dr. Matthew Kurian will be talking about the dysphotopsias. Residual cylinder, again, Dr. Vanisri. The posterior capsular opacification and capsular phimosis, this all could cause real significant problems to the patient. Dr. Sandhya will enlighten us about this. And the retinal causes, Dr. Akansha Rai will talk about it. It could be a subtle CME, the ERM, many more she'll be alluding to in that portion. So, dysphotopsias can be positive or negative. Most of the time, it is because of rays of light traversing through unwanted areas of the optic, and this can give rise to a lot of internal reflection, etc., etc. Dr. Matthew is going to cover it extensively. So you can have ghosting, you can have a dark crescent, starburst, halos, and from the picture you can make out it can be quite disabling, especially in multifocals. The early generation multifocals, you had a lot of glare, flare, halos, starbursts, or a combination, which quite a lot of is taken care of the newer generation IOLs. And this is the negative photopsias. You can see a dark crescent, temporal crescent, and the higher order aberrations. Any patients, either if we have induced a lot of higher order aberrations, or if the pre-existing higher order aberrations were very high, they can have. So all the E's can be seen, but you see, seeing the E can be different with different kind of higher order aberrations. Obviously, in the dry eye, if you have meibomitis like this, or if you have a staining like this, definitely you are going to have a lot of problem. Okay, if you look at this IOL, this lens is got a nice 0.5 to 0.7 cover of the optic. So it will take care of the effective lens position and also the centration. This also is a very well centered IOL, multifocal. But if you see this, it's not exactly what we have seen in the other picture. It's not so regular. And here again, one edge of the optic is almost uncovered. So even here, so these kind of situations, you can definitely will not have the optimum results. And here you can see a simple PC fold. This itself can cause a lot of issues. There is a double fold here, and there is a PCO here. Okay. So any patient like this, and in capsular phimosis, the patient can be very unhappy. So basically, preoperatively, you need to rule out and treat any of the causes of unhappiness like dry eye or OSD. Good keratometry, topography, and if possible, aberrometry should be done to choose the patient. OCT macula in all premium IOLs, it should be a must. Proper counseling and good chair time, and proper and correct communication and good surgical skills is very important. Postoperatively, when the patient comes to you, please evaluate the cause using slit lamp, staining, and all the investigations. Treat the dry eye if it is present and the ocular surface disorder. In residual errors, you may need to go for surgical intervention and even bioptics. Reassurance is very, very important, especially telling them that this is not going to be a progressive problem. You may have to live with it. Follow-up and proper communication is very important. Please try to follow up the patient. Thank you very much. And now I'll move on to the next part of my talk. Can you give me the next? Yeah, so I will talk about the dry eye and the ocular surface disorder. Yeah, basically, although we consider the cornea and the crystalline lens as the important refractive surfaces, the tear film, a healthy tear film, is also another very, very important refractive surface. And if there is anything wrong with this, it can cause a lot of photic phenomena, etc. And basically, dry eye is a complex disease where there is, whether it is evaporative dry eye or quantitative dry eye, there will be tear film instability, which leads to hyperosmolarity, ocular surface damage, and neurosensory abnormalities. And as you can see on the left, you have an intact tear film. On the right side, you have a broken up lipid layer, which causes osmoconcentration and apoptosis. And successful treatment is to restore the homeostasis. You could have lipid deficiency, aqueous deficiency, and mucin deficiency. Mucin, most of the time, you may not find too many number of cases, and these have to be taken care of, and the patient himself or herself will come and say they would have had some underlying disease, definitely gross disease. But aqueous deficiency and lipid deficiency are much more common. Aqueous deficiency especially associated with collagen vascular diseases like rheumatoid arthritis, SLE, etc., etc. Lipid deficiency is the most common. And, that is the one which causes the maximum damage to the ocular surface in a regular set of patients who come to us for cataract surgery. So the nonpolar and the polar lipid layer gets affected. And although there is a lot of aqueous and the mucin layer is good, this breakup causes osmoconcentration and lead to the dryness. And lacrimal keatoconjunctivitis is another term which is used. You can see the broken up polar lipid layer, and through that evaporation happening and the osmoconcentration and damage to the cells. So this is the difference between a healthy surface and an unhealthy surface leading to crenation of this thing. And in cataract surgery, we offer the patients a very painless, irritation-less surgery, and also the post-operative period, minimal rest, minimal discomfort, and it's minimally invasive. And that is the way to go. So the patient's expectations are very high. So what do we do? So how dry eye is connected to the cataract surgery? In a preoperative scenario, we either detect the dry eye during our pre-op evaluation, or you're already dealing with a patient who has dry eye. And the post-operative scenario, maybe the surgery can induce dry eye and ocular surface conditions, and or there could be a worsening of the pre-existing dry eye if you don't take care. So preoperatively, you should know it's an inflammatory disease, so the increase in bacterial load is always there, and the poor wettability of the ocular surface. So always rule out dry eye, assess the severity of the disease, if necessary, treat, stabilize, and then only operate. And make sure the inflammation, bacterial load, and the ocular surface status is acceptable. This should be part of the preoperative evaluation. And post-operative, already we are inducing inflammation, so the extra inflammation should be taken care of. So try to avoid drugs with preservatives so that you don't cause additional damage. Make your incisions as much tolerable to the ocular surface, and hygiene of the lids is very important, intraoperatively and also post-operatively. And post-operatively, you should watch out for dry eye symptoms. If the patient complains of irritation, always try to stay in and see. Try to avoid NSAIDs if possible at that point in time. Ensure adequate lubrication and ocular surface protection. And detect the ocular surface damage and titrate the use of medication. Like I said, if already there are SPKs and the induced dry eye, then try and withdraw the unnecessary medication, then use a lot of lubricant. And detecting, basically, there can be a non-obvious MGD or an obvious MGD. In both, you have to look for signs of meibomian gland dysfunction. So touching the lid, so for example, here there is telangiectasia of the lid margin, the posterior dragging of the orifices, and thick secretions. So always touching the lid margin either with your finger or with an instrument is very useful. So here is an obvious MGD, you don't need to think about it. And even then you need to press and see how the secretions are, which will give you an idea how to go with. This is the non-obvious type. Still, when you press the lid margin, you can still find that it may be even a very pasty kind of secretion from the meibomian gland. So this you can do also using instrumentation like the lipid interferometry, which can give you an idea of this thing. And obviously, the Shermer is a very useful tool. But then the cotton red, phenol red thread, it's a much better and much better reproducible because it doesn't need anesthesia, and anything below 10 should be taken as to be careful. Okay, T-Bot, always mainstay, no anesthesia, no holding, and 3 checks, and anything below 5 seconds should be considered very serious and treated. And this also can be done with a video keratoscopy or even a topography to find out, look for the first black spot. In very serious cases, you may have to go for a conjunctival impression, cytology, etc. Diagnostic staining will definitely give us a clue whether it is a meibomian gland disease or it is a diffuse keratitis, etc. And staining gives you a very important. So, treating the meibomian gland, we all know, it is to improve the flow of the meibomian secretions and a normal lipid layer. So traditional treatment like warm compressors, improved lid hygiene, and antibiotic steroid combination can be very useful. But mind you, the warm compressor, etc., is only for the pre-op patient, not for the post-op. You can do intraductal meibomian gland probing. And nowadays, we have a lot of tear substitute which contain lipids. This can be very useful for the patient. Things like LipiFlow can be used pre-op. N-acetylcysteine helps a lot. Topical azithromycin helps. Oral omega-3 fatty acids, very, very useful. And we can also use cyclosporine. So basically, when you're dealing with it, you have to understand that you have to eliminate the inflammation also, rather than just pouring in lubricants. So basically, in aqueous deficiency, there is decreased tear volume, increased osmolarity. So your idea should be to increase the tear volume. And so we have a lot of lubricants now. The cellulose esters, among that CMC is the best. Viscoelastic polysaccharides, which increase the viscosity of the tears. That helps a lot. You have hyaluronic acid, which has got non-Newtonian properties. By this, this stick on to the damaged villi and help to heal. So that's called the non-Newtonian properties. Carbomers are high molecular weight polymers of acrylic acid. So this thin while blinking, and otherwise it stays thick and it's got a long retention time. The polyol demulcents are usually used with some others. So what are the ideal constituents? Electrolytes, lipid components, especially in meibomian dry eye. This will help a lot. Petrolatum base is not very useful other than for a night application. Osmoprotection, you can use compatible solutes like taurine, carnitine, L-carnitine, erythritol, etc. So basic idea is when there is a hyperosmotic state, there will be influx of salt. These osmotic solutes will compete with that. If the salt gets in, there will be crenation. If the osmotic solute gets in a competitive at the entry gate, then cell death can be prevented. Glycocalyxomimetic agents, which is HP-GUAR, which will mimic, the glycocalyx is what fixes the aqueous, the mucin layer to the villi. These will mimic the glycocalyx proteins. So we may need to go for cyclosporine A, tetracyclines, etc., etc. Cyclosporine, I am not going to, it's a T-cell inhibitor. Short pulse dose of corticosteroids may be needed. Tetracyclines help a long way, not only as an antibiotic, but inhibiting production of inflammatory cytokines, MMP, etc. So basically, you need to treat any baseline contributing factors, stabilize this thing. Intraoperatively, you have to use extrasteroidal precautions, lid cleaning just before surgery, maintain the cornea wet throughout surgery. Many times we forget to wet the cornea. Proper wound construction techniques, minimal surgical to the ocular surface, and proper ocular surface care, including lid hygiene, advanced lubricant, careful watch on the ocular surface, and titrating them, timely intervention will be very helpful in this kind of patient. Thank you very much. Now, the next talk will be by Dr. Matthew Kurian. He'll be talking about dysphotopsias, causes, prevention, and management. Dr. Matthew Kurian doesn't need an introduction. He's a very senior cataract surgeon and the medical superintendent at Chaitanya Eye Hospital, Palarivata.
Thank you to AIOC and Sony for this opportunity. So, dysphotopsias are defined as undesirable subjective photic phenomena associated with otherwise uncomplicated cataract surgery. And they can be classified as positive, which is visible streaks, arcs, or flashes or starbursts, and a negative dysphotopsia, which is typically a temporal dark shadow. Then, of course, we have the diffractive optic dysphotopsias, which are halos, rings, or spider webs from point sources of light associated with the diffractive optics of multifocal IOLs. The incidence is unfortunately pretty high, and it is classified as the most common cause of dissatisfaction after routine cataract surgery. Up to 50% in one of the articles by Tester, and between 15 to 20% in the other articles. And it is estimated that approximately 750,000 patients yearly present with negative dysphotopsia, which is chronic. The Advisory Committee on Patient-Reported Outcome Measures for Premium IOLs has described that diffractive dysphotopsia affects up to 6% of multifocal IOLs, and this causes this requires exchange of the IOLs. And IOL exchange, which was reported in the JCRS article in 22, talks about 64 eyes of 46 patients. And out of those IOLs that had been exchanged, 83% had diffractive optic dysphotopsias, reduced quality of vision, night vision difficulties. Some were post-YAG refractive laser and post-YAG capsulotomy. All improved symptomatically, and there was no loss of corrected visual acuity. Dysphotopsias are easily measured in terms of a questionnaire, and one of the best questionnaires that I have come across is the Quality of Vision Questionnaire, which was published out of Australia, and this looks at glare, halos, starbursts, hazy vision, blurred vision, distortions, double vision, fluctuating vision, focusing difficulties, and depth perception issues. And the individual scores these based on the frequency, the severity, and the bothersomness on a Likert scale of 0 to 3. And the total is then converted, and this is a validated, rash-validated questionnaire. So if you look at dysphotopsias in the general population, we can have positive dysphotopsias and negative dysphotopsias. There is a clear correlation between the optic lab and clinic findings in positive dysphotopsias, whereas negative dysphotopsias have a poor correlation. Positive dysphotopsia is directly related to the square edge of the IOL design and the optic material, and negative dysphotopsias may be induced by any in-the-bag IOL, irrespective of the material, design, or index of refraction. In positive dysphotopsia, the position of the lens is not a factor, whereas in negative dysphotopsias, the IOL position is the key factor. Negative dysphotopsias can be measured in terms of visual functions on Goldmann perimetry, whereas only patient-reported outcomes is possible with positive dysphotopsias. There is no CNS component, so in positive dysphotopsia, whereas the CNS component and adjustment to that is quite prominent in negative dysphotopsias. So positive dysphotopsias, the root cause was described in the 1990s by Holladay et al., and ray tracing analysis of the edge was determined to be the cause. Internal reflections from the square edge was also described by 2001 and 2003. Negative dysphotopsias, on the other hand, are a temporal dark crescent, which was first described by Davidson. Holladay found that it was the IOL edge and the IOL material, along with the depth of the lens inside the gap between the iris and the IOL material. Maskett described that this was a feature of in-the-bag IOLs, while Erie called this as the illumination gap. It is simulated by a temporal peripheral light source, and it may be blocked by just keeping your hand on the side, which will block the light from the extreme temporal sources and prevent the light from entering the gap between the iris and the IOL surface and the nasal edge. Symptoms are worse when the pupil is constricted and better when dilated, and it is associated with anatomically perfect surgeries quite often. A small photic pupil and a high positive angle kappa are associated features. Higher dioptric power IOLs, negative aspheric optics, haptic orientation do not have any association with this. More common for some reason in females and in the left eye, and the symptoms may be uniocular despite similar anatomy. This is the edge gap that was shown, and it can be measured by Goldman perimetry, as in this article out of Maastricht University. The negative dysphotopsia can be prevented or relieved when the reverse optic capture is performed. It is reported to be successful in secondary reverse optic capture with an IOL exchange back to sulcus, resulted in successful outcomes in 7 out of 8 patients, as a piggyback IOL in 8 out of 11 patients, and IOL exchange with bag in the bag does not relieve negative dysphotopsia. And primarily, if it is performed, in the contralateral eye of an individual with negative dysphotopsia, reverse optic capture is almost 100% successful. So how does reverse optic capture work? Typically with multifocal multi-piece IOLs, but it also works pretty well with monofocal IOLs. And after the lens haptics are delivered into the bag, the trailing haptic is being dialed into the bag here. The optic edge is prolapsed anteriorly over the rhexis margin, and then using a second instrument by manual technique, both the optics are both edges of the optics are buttonholed through the rhexis. The side effects of this is obviously earlier onset of posterior capsule opacity, and if the haptics are fairly thick, you can have iris chafing, which would cause secondary glaucoma as well. Specific anti-dysphotic IOLs are present and are FDA approved currently. This is a video of the Femtis IOL. It's a hydrophilic lens, sort of like a plate haptic design, with the IOL being delivered into the bag. It has got flanges coming off the anterior surface of the optic, and these can be, once the trailing haptic is placed into the bag, the flanges are then anteriorized and capture the rhexis margin between the anterior and posterior portions of the lens. In individuals with chronic non-resolving negative dysphotopsias, which is disrupting to their lifestyles, IOL explant is the only option, and using good quality oculoviscoelastic devices to protect the endothelium as well as the posterior capsule, the lens can be bisected or cut at least 50%, and then it can be rotated out of the bag. Post-YAG dysphotopsia, this is an interesting case. I'll finish with this one. It's a 47-year-old male post IOL in May of last year. By November, he had glare and in November, the YAG capsulotomy was done, immediately post which he complained of glare and starburst in all directions. Treatment with brimonidine did not work, and 3 months later, post-YAG, this was the condition where this extensive amount of pearl formation on the edge of the YAG opening was causing the glare in all directions, and the YAG opening was enlarged. Following which, there were these small tags which were superior and inferior, and one floating tag in the middle, and the patient was complaining of a horizontal streak of light, which was successfully managed after treating those little fragments with further YAG. So I leave you with this management algorithm: unwanted optical images. Dark temporal crescent is negative dysphotopsia. If it is temporary, we can ignore it. If it's persistent, you need to do reverse optic capture or IOL exchange. Positive dysphotopsias, improvement with pharmacological miotic therapy. We can leave it alone. If it is not effective, we need to exchange. And in the diffractive multifocal IOL, again, if it is settling down with neuroadaptation, leave it alone. If it is not settling at the end of 3 months, we need to exchange that as well. Thank you for your attention.
Thank you, Dr. Matthew, for that very illustrative and explanatory talk on the dysphotopsias. The YAG one was very interesting, especially the tag which was in, and also the update about the newer IOL, which is mainly intended to prevent dysphotopsias. Now we go on to the next talk by Dr. Minu Mathan. Dr. Minu Mathan does not need any introduction to the AIOS or the APAO because he's an international presence. He's an accomplished and prolific cataract surgeon. He will be talking to us about the IOL centration issues, angle kappa, angle alpha, etc., as a cause of unhappy 6x6 and 6. Over to you, Dr. Minu.
Thank you, Dr. Soni, for this opportunity. Good morning, everyone. So, IOL centration issues, no financial interest in this. Ideally, IOLs should be aligned to the visual axis. We all know that. And from the title, if we say 6/6/N6, he has not mentioned uncorrected 6/6/N6. People who have monofocal IOLs also, even with correction, they may be unhappy. We will come to all those. So we should know that there is a visual axis which goes to the fovea. And there are other axes which is an optical axis and a pupillary axis. So that goes to the center of the pupil. The other one is the perpendicular one which goes perpendicular to the cornea. So there can be an angle between these two. So my talk is actually very simple. With one slide I can stop and finish off, telling that if this angle is more, and we know that this premium IOLs like multifocals and other things are more sensitive to this, and if it is more than this, do not implant, that's all. But then how do we measure all this? You can take corneal topography, aberrometry, pentacam, Lenstar, IOL master, whichever you have, they'll give you the either in millimeters or in degrees. And if it is around maybe is slightly this way or that way, but then still around 0.5, we have to be more careful, see whether the patient is too sensitive and better not to use. See, because there are multiple other reasons. See, capsular bag, see, and zonules, we don't see the zonules at all. So we don't know how the zonules are. Some zonules may be lax, some bags may be little lax in one direction. So if we happen to place a IOL in that axis, sometimes it may get decentered, it may contract more. All those things are there which we cannot assess that very well. And then during surgery, if you have a capsular axis which is discontinuous, I would not place a premium IOL or a trifocal IOL. And the size of the rexes, smaller is okay, but then if they tend to phimose, we need to identify them early and treat them, YAG them. And if it is too large, again, the optic can slightly come in front, there can be tilt, there can be decentration. So when we place lenses, all these lenses which any person gets is premium for them. We may think that only we are, some part of lenses are premium, but for the patient, that lens is premium. So let the rexes be centered and very well sized. And during a PC rent, so there are many factors which are acting. So you are tense, management totally changes, outcomes may be different. So I would not suggest these kind of premium lenses when you get a posterior capsule rupture, and they may decenter later. You never know. You place it in the bag. Sometimes small rexes may be converted into a small rent, converted into rexes may be okay. But then others, if you are not sure, please have a backup of a spherical IOL or a spherical non-premium IOL, non-trifocals. And then post-op capsular bag contraction, as we said, some myopes, some pseudo-exfoliation, some lax zonules, patients who have, very shallow anterior chamber and anterior insertion of zonules, very lax bag, thick lenses. All these, if you have a smaller rexes, they tend to contract later, and then there may be decentration. So symptoms, as Matthew was telling, all these kind of unclear feeling, contrast, distortion, glare, blurring, everything. So if it is a multifocal IOL, and if we have placed it, we would like it to be like this. The P1 and P4, when the patient is on topical and if they look at the light source, and they have to be matching, and it should be within the central ring of any of your trifocal which we use. So a rexus which is well centered and well sized will look like this. So this is a femto rexus. We can do it ourselves also. So if you mark it properly and size it, see, even now, maybe I have done quite a few cataracts. So I still cannot assess whether it is a 5.25, 4.9, 5.5. Very difficult when you do manually. So marking will be very, very useful for the centration and the sizing. And let me go on to some videos, because my talk is over. Basically, centration, decenter, don't place. Angle more than that, don't place. So this is one very old kind of, see, this was the scissors which I used to use for all types of IOLs, but this is a silicone IOL, very old one. So for this I had to use the special one, which is the serrated one. And see the second forceps which is holding it from the side. So if you want to explant, always stabilize the IOL optic with the second instrument, micro forceps holding it from the side. And this one, actually, both the haptic got disinserted. The optic was lying free. And so we cut the optic and took it out. And after that, and especially in 3-piece IOLs, if they're not coming out of the bag, so try to identify where they are fibrosed and try to move it in an axis or in a direction where it follows the curvature of the haptic. So then you won't tug on the bag, or somewhere there may be some fibrosis. We may not be able to see till the equator. But then fill up the bag with sodium hyaluronate or viscoat and try to visco dissect and try to pull out in a very gentle and a different angle than what we think it should be, directly tangential, central. That is not the idea. It should be in a direction where it does not induce any traction on the capsular bag. And so this IOL goes into the sulcus and it remains well centered. Just to show you, this is another single piece IOL placed in the sulcus. It's actually flipped also, and it is decentered. So this is another reason for decentration. So make sure that your single piece lenses go into the capsular bag. Mostly if they are in the sulcus, they may get decentered. Nobody knows what is the shape of the sulcus and where it is larger, all those things. So larger eyes and all these are difficult. But then here again, I just want to make sure that we use viscoelastic sodium hyaluronate, whichever Indian brands or whichever brands are fine. Get them into the bag, under the IOL, above the IOL, and stabilize the IOL. And if possible, we replace one IOL initially and then cut, so that the PC is totally protected. And towards the end, again, try to avoid cutting the iris and the anterior capsule margin. Be very careful and slowly cut. Don't cut with the tip. Open is slightly wider. This is a regular long tip Vanna scissors, come from any company. And after that, again put in viscoelastic. And then this incision, I will definitely make it make it from 2.8 to 3.2. Because it has to come out. There's no point in tugging and pulling, and I know that it can be brought out in a hand-over-hand technique in a 2.8 incision itself, but I don't believe these incisions remain similar after explanting and tuffing. So you see, again, another problem of the malfunctioning of the injector and this lens being shot like a missile sometimes into the bag, sometimes into the sulcus, you can have angle bleed, it can bleed from the ciliary body, it can cause zonular dialysis, it can cause PC rupture. So once we place it inside, if the pupil is not wide enough, just relocate the haptic into this one, into an area which is 90-degree opposite from that, and just retract this one and see. If it is a small PC or a zonular dialysis and it can be left alone, fine. If it is a zonular dialysis, we treat it, I don't want to go into details of this. See, I unnecessarily went into that area and aspirated and got vitreous. So do not just identify. See, if I retract, I can see that small rent area there. And if I rotate the IOL to the 90-degree opposite area, it will remain there fine. So rather than that, don't be too inquisitive to go wherever what has happened and pull on that. You can look at it, but then I had to finally do a vitrectomy. So this is what I want to highlight. Do not be too aggressive in trying to aspirate from wherever you think that there is a small piece in the periphery. So to end, this is the one which is a long-standing one, patient having glare. So this is the one thing. Pupil when constricted, see it is a little decentered here. There you see fibrosis here. The P1 and P4 are within the optic itself. And if you put a pinhole, patient is happy about it. So here we wanted to size this is the pupilloplasty. There is no, the lens is very well stuck within the bag and fibrosed. No movement, no pseudophagodonosis. So this is the way I do a pupilloplasty, 4th-row pupilloplasty. So take one bite and bring it out on either sides of the pupil and bring it out. Make 4 throws along the loop and then pull it inside. 1 knot is enough. You don't have to bring it out, make multiple knots. So again, if you feel that it is not small enough, you can make sure that the P1 and P4, especially P1, is within the pupillar area. And we can make one more so that the pupil is small and you don't get the edge of the lens within the pupillar area. And then one more, again to show you 4 throws. Different ways of taking 4 throws, but then this is one way to take 4 throws on the loop. And then you can use an AIOS or a 10-0 proline, and then with one pull, it just closes down. So if you feel that the pupil needs to be a little more decentered, you can use a vitrectomy cutter to cut the edge of the pupil here, or you can make 2 or 3 snips on the edge of the pupil so that the pupil is slightly larger and the P1 is well centered within this one. So these are some ways of correcting these kind of decentrations, and thank you very much.
Thank you, Dr. Minumathan, for that very illustrative talk with a lot of excellent videos. Now I call upon Dr. Vanishri Nair to talk about residual cylinders and higher order aberrations as a cause of unhappy 6 and 6. Dr. Vanishri is a consultant cataract surgeon at Giridhara Institute, Cochin, and a prolific surgeon. Over to you, Dr. Vanishri.
Thank you, sir. So I'm talking about residual astigmatism and higher order aberrations in a cataract surgery patient. So as we all know, now the cataract surgeries have become refractive surgeries. Patients are having higher expectations, and it's also our duty to try and give the best outcome to the patient, because that's an opportunity where we can give him a specs-free vision or probably, a good unaided 6/6 vision. So understanding the ocular aberrations. So as we all know, most of the aberrations are actually the low order aberrations. 90% of them are your defocus and astigmatism. So first we need to handle those. And higher order aberrations actually make up 10% of the remaining aberrations. That is, spherical aberrations and coma are the ones which are relevant to this talk. So coming to small residual astigmatism. Now what happens is, if a patient is left with a small residual astigmatism, it causes small distortions for the unaided vision. Patient may have a good 6/6 vision with glasses, but unaided there is distortion, and that can be a reason for unhappiness. So as we all know, in astigmatism, there are 3 components. It's the corneal, lenticular, and the retinal. The retinal component we cannot really, change, but we can take care of the corneal and the lenticular part. Now, the lenticular astigmatism is gone once we do the cataract surgery, so we have to pay attention to the corneal aspect. And in the corneal aspect, we have to remember that it is regular and irregular. It is the regular astigmatism is what we can actually correct with our toric IOLs. So a pre-existing regular corneal astigmatism, more than 0.75 or 1 diopter, is what we can correct with the toric IOLs. And mind you, there is no contraindications to toric IOLs. So even patients with glaucoma, epiretinal membrane, macular degeneration can also benefit from toric IOLs, unlike the trifocals or other IOLs. But we have to be careful that if the cornea is irregular or the patient requires an RGP or scleral contact lenses, these patients are not good candidates for toric IOLs. So coming to the preoperative evaluation. So now we know that the corneal and the lenticular astigmatism will be present when we are checking the preoperative refraction. So that is not what we have to look at. What we have to look at is only the keratometry readings, because that is what going to matter for the corneal astigmatism. So there are two aspects, with the rule astigmatism and against the rule astigmatism. So in the older population, it is the against the rule astigmatism which is more common. That is, the steeper axis will be along 180 degrees. Another component that is important here while doing biometry is the posterior corneal astigmatism. The effect of the posterior corneal astigmatism was previously missed because only the anterior curvature was noted by the older biometers. So this effect would lead to a mean overcorrection of 0.5 diopters in the with the rule group and a mean undercorrection of 0.3 in the against the astigmatism rule. This was given by Dr. Douglas Koch. So now the newer, the modern optical biometers, they take into consideration the posterior corneal astigmatism. Lenstar actually compensates for PCA. IOL Master 700 calculates the true PCA, and the online formulas like Barrett's universal formula and the toric calculators, they compensate for the PCA for the calculations. So coming to an example, so here if you see, the astigmatism is showing only 0.62 at 3 degrees, so you would say that it is not very significant, but if you actually compensate for the posterior corneal astigmatism, it becomes significant, and there is a 1 diopter astigmatism at the level of cornea, which will remain as a residual cylinder, so you better use a toric IOL here. This is a similar example of against the rule astigmatism, where correcting with a T2 would further reduce the cylinder to 0.13. Now, in the earlier days, it was thought that axis flip will cause a problem. So they used to leave a more residual cylinder to avoid the axis flipping. But then it was realized that flipping a small amount of cylinder is actually tolerable and preferable when treating against the rule astigmatism. But if it is a with the rule astigmatism, then you shouldn't flip the axis, because we want to leave some residual with the rule astigmatism. Target ideally should be 0.34 of residual with the rule astigmatism. The reason being, the cornea goes from with the rule to against the rule as the patient ages. So every 5 years, the cornea will change on its own. So it's better to target a 0.35 diopters of with the rule astigmatism. So try to correct astigmatism. It will give a better quality of vision to the patient, making them 6/6 happy. And with the rule astigmatism, 0.3 to 0.5, it is better to leave alone. Okay, coming to the high order aberrations, I'll quickly touch upon the high order aberrations which are practically relevant here. That is coma and most importantly, spherical aberrations in cataract surgery patients. So the aberrometry, wavefront aberrometry is actually used to know the total aberrations of the eye, and we quantify them using the Zernicke's polynomials and Fourier analysis. So how do we measure the wavefront aberrations? So they are measured at 2 levels. One is the cornea and the pupillary plane, and second is at the retinal level. So at the retina level, the 3 aspects, that is the point spread function, Strehal ratio, and modulation transfer function is what is measured. And at the cornea level, what we get is the wavefront analysis, which is quantified in terms of root mean square analysis. Now just touching upon what is point spread function. So it is the image that gets formed by the optical system of a point source of light. Now in aberration-free optics, it will form an airy pattern, as you can see in this diagram. But in the eye, because of the pupil size, it affects the airy pattern. So it will form a circular image, and ideally, the ideal point spread function is measured at 6 mm. Hence, when the pupil is at 6 mm, the point spread function is measured. Strehal ratio, again, it is the ratio of the point spread function of an optical system to the ideal point spread function of an aberration-free system. So if you say that the Strehal ratio is 1, then it's a perfect optical system. 0.9 or 0.8 would be a good ratio. 0.4, 0.3 would be not so good. Now we have an instrument called the ITRIS, which actually gives us wavefront analysis, corneal topography, keratometry readings, and pupillometry. So it gives out your point spread function, Strehal ratio, and modulation transfer function in a nice way. So we can, before we put a premium IOL, we know what are we dealing with in terms of high order aberrations. Similarly, the pentacam will also give. So coming to important important higher order aberration, that is the spherical aberration, which is relevant for the cataract surgery. So what happens in the eye is, when the patient is young, the cornea is having a positive spherical aberration and the lens is on the negative side. So it compensates and there's no total spherical aberration. As the patient ages, what happens is the lens also starts developing cataract and has positive spherical aberration. That leads to a moderate amount of positive spherical aberration in the eye. Now, if we are using a standard IOL, the standard IOL has a lot of positive spherical aberration. The patient lands up with a lot of positive spherical aberration in the eye, and that gives rise to problems. So there are two lenses that we have, that is a zero spherical aberration IOL and the negative spherical aberration IOL, what we call as the aspheric IOLs. So these aspheric IOLs actually help to prevent spherical aberrations getting formed, but at the cost of depth perception, because a little amount of spherical aberration actually gives us the depth perception. So I just spoke about this. So traditional IOLs are the ones which have the positive spherical aberration, and the aspheric IOLs, which we are using now, which we call as the premium IOLs, are actually divided into two, that is zero aberration and negative aberrations. So I borrowed this from Dr. Uday Degan. He made a decision tree basically to help us understand in which kind of patient which IOL would be better. So when we have a patient who has not had any prior corneal refractive surgery and the IOL is not likely to decenter, we know that the IOL is going to remain in center, then, and the depth of field is critical to the patient, then we should go ahead with a aspheric IOL with zero spherical aberration. If the image quality is what the patient wants to be very crisp, then go with the negative spherical aberration. But if the patient has had a hyperopic LASIK, then we need to put, in hyperopic LASIK, the cornea becomes more oblate. So we need to use a IOL with a positive spherical aberration. If the patient has had a prior myopic LASIK, then we need to use an aspheric IOL with a negative spherical aberration. So just sharing some examples. So your traditional IOL would be something like a sensor, negative spherical aberrations, Acrosoft, Technis and Vivinex, and zero spherical aberration, Bausch & Lomb and Vista. So I already spoke about this, the cornea after refractive surgery. So just take home points. So target correction of the lower order aberrations first. Defocus and astigmatism we have to have perfected. Then focus on the higher order aberrations. Most important higher order aberration that we need to look at is the spherical aberrations. Do a tomography, find the total amount of higher order aberrations are there. If the higher order aberrations are more than 0.4 RMS, then you should avoid multifocals or the true EDOFs. Thank you for your patient listening.
Thank you, Dr. Vanushree, for that very elaborate and very descriptive talk and how to avoid problems. And now we go on to the next talk by regarding the posterior capsular issues and capsular phimosis by Dr. Sandhya. Dr. Sandhya is a senior consultant at Giridhar Eye Institute, Cochin. She's a prolific cataract surgeon and also a UVA consultant. Over to you, Dr. Sandhya.
Thank you, Dr. Soni. So I'll be dealing with posterior capsule issues and capsular phimosis. So this 70-year-old gentleman underwent phacoemulsification with multifocal IOL implantation. Post-cataract surgery, his unaided visual acuity was 6.6 and 6, but he complained of tailing of light. So examination, the multifocal IOL was well centered with the uniform overlap of capsular axis all around, and the anterior chamber was quiet. But there was a linear fold on the posterior capsule which was causing these symptoms. And after YAC capsulotomy, he was relieved of symptoms. Now, the capsular folds or wrinkles are mainly of two types. The first type is the broad undulations of clear capsule, which are common in the early postoperative period before the capsule tenses. And posterior chamber intraocular lens also can induce broad wrinkles along the axis of the haptic, but they rarely produce any visual disturbances. However, some patients can complain of linear distortion. In contrast, fine wrinkles due to capsular fibrosis, they occur late in the postoperative period and they produce marked optical disturbances. And visual disturbance due to either early or late capsular folds or wrinkles can be treated with capsulotomy. Now this patient, post-cataract surgery, had 6.6 vision, but he complained of glare and increased light sensitivity, especially at night. And this was his presenting complaint before surgery, and the surgery did not produce any difference. And he had early early posterior capsule opacification, and he was treated with capsulotomy and he was happy. But before doing YAC caps, we should rule out other causes of glare and increased light sensitivity like ocular surface disease or the multifocal IOL itself, because a YAC capsulotomy can complicate the explantation of the multifocal IOL if that is the cause, if the need arises in future. Now the PCO can be of two types. The fibrous type is due to abnormal proliferation of lens epithelial cells, and the pearl type, which is the commonest type, is due to normally differentiated lens epithelial cells. And this 76-year-old lady underwent phaco 1 year back, and she complained of blurring of vision, and her best guided visual acuity was 69 parts N8. And there was this cloudy appearance in the pupillary area. The intraocular lens was well within the bag, and the capsular axis was uniformly overlapping the IOL optic. On slit examination, a cloudy fluid was present between the intraocular lens and the posterior capsule, and anterior segment OCT showed hyperreflectivity between the intraocular lens and posterior capsule, and this was capsular bag distension syndrome. Capsular bag distension syndrome is invariably associated with in-the-bag IOL placement, and the capsular axis is relatively smaller, and it overlaps the IOL optic all around and will stick to it. So the residual lens epithelial cells, when they proliferate and produce extracellular matrix and collagen that accumulate between the lens and the posterior capsule, and later on it becomes cloudy and causes reduction in visual acuity. And so the diagnosis in the early stages can be made by AIOS2025-IC16-66 and UBM, but when the patient becomes symptomatic, a slit lamp examination can clinch the diagnosis. And after capsulotomy, the turbid fluid was released into the vitreous, and the patient had a good visual acuity. Now, in the undilated position, this can be confused with dense posterior capsule opacification or IOL opacification, but a dilated examination will help in differentiating these conditions. And the differentiation is important because in CBDS and PCO, capsulotomy is the treatment of choice. But in lens opacification, if you do capsulotomy early, then the explantation will become difficult. Now, though this patient had 6/6 vision, the quality of vision was poor because of the presence of vitreous in front of the IOL. And then how can we prevent the posterior capsule related issues and PCO? So you should make a good capsular axis which will uniformly overlap the IOL optic all around, so that it will have a shrink wrap effect on the over the IOL optic, protecting it from the harmful macromolecules within the aqueous. And the hydrodissection should break all the capsulocortical adhesions, and you should remove the cortex completely. Now this square truncated edge of the modern IOLs, it will prevent migration of the lens epithelial cells from the equator to the center, reducing PCO. And also the in-the-back placement of the IOL will prevent adhesion between the anterior rexus margin and posterior capsule. And also a good capsule polishing will remove the residual lens epithelial cells, reducing PCO. Now coming to capsular phimosis, there is progressive contraction and fibrosis of the capsular rexus margin, potentially obstructing the visual axis, and also it can produce late IOL changes like pseudophacodonosis, IOL tilt, decentration, or even subluxation or dislocation because of progressive zonular weakness or dehiscence. Now it is due to the metaplasia and fibrosis of the lens epithelial cells at the capsular rexus margin, and this is exaggerated by the imbalance between the centrifugal forces and the sphincter effect of the rexus margin. And the smaller capsular axis, zonular weakness, advanced age, and high myopia are all risk factors for the development of capsular phimosis. It can be reduced by making a larger capsular axis and also by meticulous lens epithelial cells cleanup at the time of phacoemulsification. A can-opener capsulotomy rather than a continuous curvilinear capsular axis is associated with less incidence of capsular phimosis. Now, as told, it can be asymptomatic or there can be progressive diminution of vision. Glare halos or monocular diplopia will be there when the lens is grossly descended, or when it is dislocated, there can be sudden loss of vision. Now, in this patient, he had a pseudo-exfoliation, and then there was a increased gap between iris and the cataract, indicating some zonual weakness. And as you can see here, when the rexus was initiated, the entire lens back complex was moving, suggestive of zonual weakness, and the lens was nudged after hydrodissection. The capsular rexus came to the center. That again points to zonual weakness, and the entire capsular bag was shaking during emulsification, and I had to keep this Sinski hook behind the phacoprobe to prevent aspiration. So identifying these signs of zonual weakness intraoperatively is important so that we can take proper precautions and can prevent the occurrence of capsule phimosis and decentration of IOL. So in this patient with severe zonual weakness, CTR was placed inside the bag and a 3-piece lens was injected into the anterior chamber, and the haptics were carefully placed in the sulcus, and the optic was taken under the rhexis margin and captured. So the CTR will expand the capsular fornix, and the 2 haptics in the sulcus will give extra anchorage to the lens, so preventing its decentration. Now in this patient, during phacoemulsification itself, CTR was used, and then once the IOL was implanted, I felt the rhexis was small, so multiple radial nicks were made using a micro-rhexis scissors so that the capsular rhexis opens up and the sphincter action is less, so there is less chance of capsular phimosis. Now this patient had mature intumescent cataract, and the rhexis was done in 2 stages. And when the IOL was inserted, the haptic was folded and there was eccentricity of the rhexis. So it was enlarged after the insertion of IOL so that the forces acting on the rhexis margin becomes uniform. This patient had posterior capsule opacification and capsular phimosis. So at first, an opening was made on the posterior capsule using ND-arc laser, and then multiple radial nicks were made on the anterior rhexis margin so that the rhexis margin opens up and there is no progression for capsular phimosis. This video was given by Dr. John. And in this patient, progressive capsular phimosis and zonular weakness has got decentration of the IOL bag complex. So this is more common in patients with pseudo-exfoliation as mentioned previously. So in such cases, we need to explant the IOL bag complex, and we'll have to do some form of secondary IOL procedures like iris glow as seen here, or any other form of scleral fixation to restore vision. Now to summarize, suboptimal visual outcome in spite of normal Snell's visual acuity is not uncommon due to various capsular issues, and it is important to identify them and treat accordingly. Thank you.
Thank you very much, Dr. Sandhya, for that very illustrative talk with excellent videos on how to prevent and how to deal with these issues. Now we come on to the odd man or the odd woman out among us, vitreoretinal surgeon. So Dr. Akansha Rai will be talking about the retinal causes for unhappiness in a post-cataract patient. Over to you, Dr. Akansha.
Thank you, sir. Good morning, everybody. So I'll be talking about the retinal causes and management in an unhappy 6/6 patient post-cataract surgery. And first of all, let me thank my mentor, Dr. Soni Jos sir, and AIOC Scientific Committee for providing me this opportunity in this wonderful instruction course. So with this, as we know, that advanced surgical techniques have improved the outcomes of the cataract surgery, as well as the patient expectations have also increased. And also there are pre-existing conditions, retinal conditions, which cannot be diagnosed pre-operatively sometimes due to the cataract haze, or it might be induced post-operatively, leading to a 6/6 unhappy patient. So with this background, I'll be showing few cases which I have got from my cataract department, and then we'll go on to the discussion. So this is the first case. A 58-year-old lady came to us with a pre-op visual acuity of 6/18. She was diagnosed to have cataract in the left eye, and surgery was done. It was an uneventful surgery. Post-op visual acuity improved to 6/6. Post-operatively, she started complaining of a black dot in front of her left eye, operated eye. We went ahead and saw her fundus again. There was nothing in the fundus. OCT scans were reviewed, and in one of the sections, as we can see here, there was a hyperreflective dot in the inner retinal layers and a hyporeflective dot in the outer retinal layer, which was typically suggestive of solar or a photic retinopathy. On further interrogation, she accepted that recently she has started worshipping sun god, and history of solar gaze is there. And this was an example of solar retinopathy, which was picked up post-operatively. So if a thorough retinal investigation was done, it would have been picked up earlier. Okay, so this, the second case is a 65-year-old lady. Preoperative visual acuity 6/36 improved to 6/6 parts. Surgery was uneventful, And even having 6 parts, she complained of blurring of vision in the left eye. Again, we went back and saw her fundus. Now we can see very small subtle changes in the fundus, as we can see here along the superior arterial arcade. There was cholesterol plaques in the artery, which is suggestive of some old arterial occlusion. Also along the inferior arterial arcade, we saw small retinal hemorrhages in the nerve fiber layer, superficial retinal hemorrhages suggestive of a venous occlusion. So with these two things, we came to a conclusion that there is some vascular compromise in this eye, and the decrease in vision probably is due to the macular ischemia due to these vascular events, and she was referred to a physician. The third case was a 58-year-old gentleman who came to us with cataract, and post-cataract surgery, his vision improved to 6/8 parts. Surgery was uneventful, but he was typically complaining of a black horizontal linear band in his inferior field of vision, which he was very sure that there is a linear horizontal band. We saw his fundus. On fundus, we found that there was a white horizontal lesion above the fovea, suggestive of some small arterial occlusion along with thickening of the retina, and the corresponding area on the OCT showed thickening along with a hyperreflective band in the middle retinal layers, which is typical of parafoveal acute middle maculopathy, which is seen associated with vascular events in the eye as well as systemic vascular events. So here the patient was investigated further for systemic conditions. On systemic examination, he was found carotid Doppler showed diffuse atherosclerotic changes in the left internal cerebral artery and the common carotid artery, and a bifid curve in the right internal carotid artery. So by looking at the eye, we came to the diagnosis of these systemic things, and the patient was referred to cardiologist and medication started. In this case, the most important thing is we counseled the patient about the guarded visual prognosis in this eye in future. So there are also previous case reports where identifying a paracentral acute middle maculopathy has led us to detection of the systemic conditions. This condition is actually a focal ischemia of the deep retinal circulation that may herald the presence of secondary underlying condition. OCT is invaluable in identifying this condition. OCTA shows us a capillary loss at the deep capillary plexus level, and the patient typically complains of a paracentral scotoma, and the vision may or may not be decreased. So these patients warrant a thorough systemic evaluation. The fourth case, this case was our old case, which was a known case of retinal pathology, which we were following her up for past 4 years. Post cataract surgery, her vision improved to 6/6, but she was complaining of blurring of vision in the right eye. So as we can see here in the fundus image, there is straightening of the retinal vessels along with a membrane, a shining membrane over the fovea, which is suggestive of epiretinal membrane. And the OCT also shows grade 2 epiretinal membrane where the foveal contour is lost, and nasal to the fovea there is thickening of the retina, but the vision was still good 6/8 because the epiretinal membrane was not distorting the fovea, and it was distorting more the parafoveal area. So the vision was preserved to 6/8 parts, and we are following up this case. Here, since the patient was counseled before the surgery that she is having an epiretinal membrane and the visual outcome will be suboptimal, there were no much complaints from the patient side. The fourth case is also our old case, and she was being followed up by us. She came with cataract, operated, vision improved to 6/6 parts, but after surgery, she was complaining of blurring of vision in the left eye, and she was a case of parafoveal telangiectasia, but since the patient was a known case of parafoveal telangiectasia, there was no much unhappiness from the patient side, and she was counseled beforehand. So with this, with this background, I'll come to the other causes which can lead to 6/6 and 6 unhappy patient retinal causes. It can be divided into vascular, inflammatory, degenerative, and dystrophy. The vascular can be minor arterial or venous blockage can be there. In case of arterial or venous blockage, we have to go ahead with the systemic investigation and refer the patient to the physician or the cardiologist, whatever is required in the cases. Also, the other causes for unhappiness can be small, like there can be a mild vitreous hemorrhage, post-cataract surgery from the peripheral neovascularization, and during the surgery vitreous is disturbed and which has led to a small amount of vitreous hemorrhage. The next cause is inflammatory, can be pseudophakic cystoid macular edema, which can be treated with topical NSAIDs pre and post-operatively. Old uveitis, which might be missed pre-operatively or flared during the cataract surgery. Subclinical endophthalmitis can be there with low virulence organisms like GPC. Masquerades and photic or solar retinopathy. Subclinical endophthalmitis should be treated in masquerades, but photic and solar retinopathy have a very good visual prognosis and they only need is observation. Degenerative causes can be complete or incomplete PVD induced during the surgery. Subfoveal or fovea awaiting drusen, which needs observation only. Asteroid hyalosis can be there. Usually asteroid hyalosis patients don't complain of any visual, they don't have any visual complaint, but rarely post-surgery, these asteroid bodies can come and they can get accumulated behind the nodal point, and then the patient can complain of decreased vision. In those cases, only vitrectomy or YAG laser vitreolysis may be needed. Other degenerative causes are parafoveal telangiectasia and epiretinal membrane, which I showed in my previous cases. If they are present, they need to be followed up, and if at all they are progressing, they need treatment. The last one is the vitreomacular adhesion or traction. Sometimes what we think as a vitreomacular adhesion can be a vitreomacular traction, which has led, and the vitreous movement during the surgery has led to mild cystoid macular edema, leading to patients' unhappiness. In those cases, we have to do ultra high resolution OCT, because standard resolution OCT is capable of 10 micron axial resolution, which can miss small amount of macular edema or a cystoid macular edema. But if we go ahead with the ultra high resolution OCT, which is capable of 3 micron axial resolution, if a small amount of cystoid macular edema will not be missed, and if at all there is small macular edema in these unhappy patients, can be picked up with ultra high resolution OCT. Other than this, there can be a dystrophy, early retinitis pigmentosa sign pigmento, where the fundus is not having the typical features of pigmentation in the periphery, and post cataract surgery the patient will be unhappy. So with this, the take home message is selection of cases for multifocal, trifocal EDOFs should be very stringent, and detailed preoperative retinal evaluation and imaging is important to select this patient. And here, since the vision is 6/6 and 6, most cases will not need any intervention. The retinal lesion is very small, non-progressive. They only need is preoperative reassurance and proper counseling. Thank you so much. These are my acknowledgement.
Thank you very much, Dr. Akansha, for that very descriptive causes, and makes me a little more scared when dealing with these patients, because a few of them are unknown to me. Thank you very much for making it very interesting. And now we move on to the keynote address. It will be my pleasure to introduce the keynote speaker, Dr. Fasika Oreta from USA. She is the Professor of Ophthalmic Education and Associate Professor of Ophthalmology, the residency program, and the Director at the Eye Trauma Center, Wilmer Eye Institute, Johns Hopkins University and School of Medicine. And she'll be talking to about corneal complications after cataract surgery. Over to you, Dr. Fasika.
Thank you so much, Dr. George, for the opportunity to speak to close the session out. I learned lots from my colleagues. I have no financial disclosures. I'll acknowledge my grant support. So today I'll be talking about common and uncommon complications, corneal complications of cataract surgery. As cornea specialists, still most of what we do is cataract surgery. And as we will see, the theme of my talk is prevention is key. So the most common complication is the Descemet's membrane detachments. We'll also talk about more rare ones like wound burn, and some we rarely see today like epithelial downgrowth. So as I mentioned, Descemet's membrane detachment is the most common complication following cataract surgery. Fortunately, most of the time it is not significant, and it's small at the site of the incision and resolves spontaneously. But the incidence of visually significant DM strips after phacoemulsification surgery is about 0.04%. And from this study that was published in Cornea about a decade ago. And what they defined as visually significant was more than 1 quadrant of edema and or affecting the visual axis. So when we look during using intraoperative OCT, as shown here, you can see that the incidence of DM strips are actually quite common during surgery. So this was a study that was published in JAMA Ophthalmology. It was a prospective study of about 130 patients undergoing cataract surgery. And you can see here using anterior segment OCT, they imaged for the evidence of DM strips. And basically they found it in 94% of eyes. Most commonly occurred during the step of phacoemulsification, followed by irrigation and aspiration as the second most common step. But again, fortunately, we know that 94% of the time it's not visually significant, so only a small portion of that will be visually significant. So what are some factors associated with DM strips? Blunt blades, if we make a surgeon factor, such as making a long, narrow wound. There are some patient factors as well, such as older age, shallow anterior chamber, and finally, the dense cataract and longer duration of surgery is associated with DM strips. So how to prevent this? We avoid creating long wounds. You can consider using wider incisions for dense cataracts. I always, when I'm teaching my residents, they always want to put their instruments through the large main wound, but I always say to go through the side ports when possible. And finally, when you recognize a DM strip, then you can abandon the use of the main wound and use bimanual, for example, to avoid use. And then for those who do femtosecond laser-assisted cataract surgery, you can see here the anterior segment OCT of the wound, and the configuration is more smooth. And in this study, they found that the DM strips were less with the femtosecond laser. So it was observed in 10% of cases where the wound was made with the femtosecond laser versus in nearly 50% of the conventional phacoemulsification. But importantly, again, the DM strip was self-resolving and did not persist at 1 month in any group, and the visual acuity was the same in both. So how do we manage the DM strips? Well, if you notice it at the end of cataract surgery, and usually if it's more than 1 or 2 millimeters, I'll just leave a small air bubble in. But it's important if you have patients with persistent edema after cataract surgery to think of DM strips and image with anterior segment OCT. And then you can treat by putting air or SF6 gas in the anterior chamber. So this was a study that was published in American Journal of Ophthalmology case reports, where it was 5 patients who presented weeks to months after cataract surgery with DM strips. Some cases required rebubble with air or gas, 2 spontaneously resolved, and 1 did require an endothelial keratoplasty. Moving on to wound burn, which is unfortunately a rare complication. So based on the survey that was done in the Journal of Cataract and Refractive Surgery, the incidence is about 0.4%. So there are some signs when you're going to get a wound burn, such as whitening of the cornea at the incision and milk around the phaco needle. So these were images shared in this publication shown here. So you want to recognize wound burn early and stop, because it can be very hard to manage if you don't recognize. And some risk factors, including using a lot of phaco energy, again, making a long wound, using Helon 5, and if your irrigation there's a kink in your irrigation, so you always need to check before entering the eye. So this is a photo that was a courtesy of Dr. Devkin at UCLA, and you can see this is a wound burn where you can see shrinking of the corneal tissue. So again, these can be hard to suture, often requiring multiple sutures as shown here. You can use a bandage contact lens, and sometimes glue or a patch is necessary in severe cases. Moving on to the complication of corneal melt or perforation. So the use of non-steroidal anti-inflammatory agents have been associated with melts. So you want to avoid these in patients with significant dry eye disease, ocular surface disease, or autoimmune disease. So again, this is an example that was published in AJO case reports of 3 sterile melts after cataract surgery, again in patients being treated with non-steroidals and had a history of autoimmune disease. Wound infections, again rare, but can happen. So in this study that was published over 20 years ago, you can see the organisms that were the most common, so staph, strep, and 3 of these wound infections were associated with endophthalmitis. So you can see here a infiltrate at the temporal wound, and then in the case number 2, a superior wound with associated scleral abscess and endophthalmitis. Sometimes these do require lamellokeratoplasty and conjunctival flap as shown here. We also see some atypical organisms depending on the setting we're in. So this was a study published out of Bascom Palmer where they had non-tuberculous mycobacterial keratitis at the clear corneal wounds. This was a study this was a patient that was referred to me at Hopkins, where you can see they presented with a wound abscess. There was actually a loose suture here, which I removed, and the patient presented with low IOPE, choroidals, and required a patch graft in order to save the vision. Pseudophakic bullous keratopathy, fortunately, is less common today than in the past due to improvements in cataract surgery techniques and IOL design. So in the US, the incidence is about 0.1%, and globally varies, but about 1 to 2%. So risk factors include dense cataracts, surgical trauma, pre-existing endothelial disease. And most of the time nowadays, we see this not after cataract surgery, but after glaucoma surgery. So this was a patient that was referred to me after anterior chamber intraocular lens placement. So you can see the trauma at the surgical wound, which was enlarged to accommodate the ACIOL. So there's significant scarring, edema, and you can see on tomography the corneal thickness is over 1,000. So this can be difficult to treat, and so again, preventing this is essential. So in conclusion, corneal complications are rare, but they can be potentially devastating. So preventing, recognizing early, and appropriate management is essential. Thank you again for the opportunity to speak, and if you have any questions, my email's on the bottom. Thank you.
Thank you very much, Dr. Fasika, for that overview on the corneal complications of cataract surgery. In fact, we should thank you for coming all over from US and enlightening us on this special topic. Now we have another 7 minutes to go, and if there are any questions from the audience, we'll be ready to take it to any of the panelists, including the keynote speaker. Are there any questions, please?
You can use the mic there.
Good morning, everybody. Good speech. My question is to Minu. Yeah, you've done few more surgeries than me, so I guess you're the best person to answer this question. I was seeing your videos, and now you are telling us about not implanting a premium IOL if you had a small problem. Question is, if this particular patient has had a premium IOL in the other eye, what would you do?
Can you repeat the question, please? Yeah.
If the other eye has got a premium IOL and you don't want
Oh. And you other eye had a premium IOL and you have promised a premium IOL in this eye, you have a complication, you want to change the IOL. You cannot place a premium IOL. What do you do? Okay. What do? We don't place a multifocal IOL. That's it. If we cannot place. But then the problem is, last month we had a patient who was trifocal in one eye. But she had severe glare and halos, and she was not told about it. And she said, it's very difficult for me to proceed with this. I don't want this IOL in the other eye and all those. So we placed an EDOF IOL, actual EDOF IOL. And she was quite happy, and that other eye problems also reduced. So many patients do, and she had 66 N6 anyway in this eye, and other eye had a slight N8 for very close up. So, but the problem is if you have a PC rent and you cannot place a trifocal, then you will have to go for a regular three-piece, multi-piece IOL in the sulcus. But otherwise, if you can place, you can always place a EDOF, which is more forgiving. Like I don't have any financial interest. The eye hands variety, which is not exactly an EDOF, it's an extended monofocal or a monofocal plus, which will give definitely intermediate, good intermediate, and the other eye multifocal will definitely work. And there is no harm having one eye trifocal and this one if you have a problem.
One option would be the Femtis IOL kind of lens, where if you have a zonular dialysis, you can put a CTR and then it will capture in the rhexis margin. If you have a PC rent also, one set of haptics go into the back, the other set of haptics sit in front of the rhexis margin, and that is it's available in toric design. It is available in the extended depth of focus kind, about plus 1.5. Only criteria is that it has to be done with a femtorhexis, because the rhexis is very critical in sizing.
You can also, either with the EDOF IOL or with a monofocal, you can do a micro monovision, leaving around 0.5 to 0.75 in that eye. And that also can make the patient happy. I hope we have answered the question somewhat.
Again, this is an unplanned thing which we are talking about. We have promised totally, and it's an unplanned thing. Again, we'll have to decide whether to implant this without telling the patient, or on the table, if you tell the patient also, no, sometimes they don't understand all these things and come back and tell that I didn't know, I didn't hear anything and all this. So that also is a very significant thing. So if patient realizes and understands, we should be telling on the table and then placing. Without telling anything, and if you place and then post-op, if you try to explain, it's very difficult. But technically and scientifically, these are the answers.
And I think another point is if the patient has is unhappy from a diffractive lens, sometimes, as we mentioned, there's a 5% exchange rate. So if they're unhappy in one eye, I would not proceed with the other eye until they're happy. So I've seen cases where they have two diffractive lenses and they're unhappy. And they said they were never happy from the beginning. So then they have to have a bilateral IOL exchange. So, you know, there is neuroadaptation, but again, if they're significantly unhappy with the first eye, I would wait before putting it in the second eye in case they need an exchange.
We're talking about a patient with a happy operated eye. So I basically want to ask, I know the options you've given are absolutely fine, but based on your vast collective experience, is it possible to go ahead and still place this premium IOL if you have a minor problem? I'm not talking about a major issue. Can we go ahead?
And mind block. Yeah, whether it's because of the
can
mind
you go
block
ahead?
of the patient.
Can you go ahead with the same?
Yeah.
See, in experienced hands, you can't have a major complication. Probably small PC rent or a bit of a dialysis in some corner or something like that. Can you still go ahead with your premium?
You're talking about the second eye.
Yeah.
Okay. I think we should take all precaution, try to get that unhappiness out of his mind. The last may be a distraction technique. So if you're able to get him at least 75 to 80% onto that, then definitely I think we can go ahead with the second eye. Yeah, I think we have come to the end of the session. Thank you very much. Thank you, audience, for coming for this, early morning session of the first day of the conference. And I thank, it's really appreciated. And thank you all my co-panelists and the keynote speaker for making this session very useful. And let us have a group photograph.